Okay, next up, we have Dr. Vyshak Venur from University of Washington and Fred Hutch Cancer Center. He's actually going to talk a little more, keep the conversation going related to IDH1 and IDH2 and what a potential FDA approval for Vorasidenib means for future treatment of low-grade gliomas. I'm very excited to hear your presentation, Dr. Venur, and I want to thank you in advance for having some patience as we run a little bit long in this program. Thank you. Welcome.
Well, let's see if I can share properly. Thank you, Dylan, and rest of the team at Brain Cancer Initiative for inviting me. I came, I believe, 2 years ago to give a talk here about clinical trials at Hutch and what we're doing for neuro-oncology. I also want to congratulate all the awardees and nominees for the HOPE Award. I think, HOPE is the reason why I do what I do, and you patients are the reason why we do all kinds of research and everything that we do for at our center here and as neuro-oncologists. So thank you. I have no disclosures, so I pretty much can talk about almost anything that I practice. I have some slides. We are running late, so we could do several things. We could talk about some of the basics of low-grade glioma and take it from where Dr. Dewey left in terms of all the treatment options that are available. We could talk about some science, but we could also talk about anything that patients want to hear from me in terms of questions on low-grade gliomas, glioblastoma. This is where I live and breathe, and other tumors in the brain. But low-grade glioma, the treatment pillars are 3 major pillars, and you've heard about a lot about radiation therapy, local radiation therapy like gamma tiles. You've heard about some of the surgical approaches and systemic therapy, which is what I do most of the times. As our surgeons do the surgery, the radiation oncologists are delivering radiation, and then patients come to me for systemic therapy options. But these are the 3 pillars, and we have to think about what goes first, what goes next when a patient with brain tumors, whether that's high-grade glioma or low-grade glioma, comes to our team. And it really is a multidisciplinary approach, as we have been all talking about. But low-grade glioma is a very unique subset of primary brain tumor. And to be honest, patients with low-grade gliomas are often younger patients. They usually are either starting their career or they're in their journey through having family or having young kids. And these are patients in the age group of 20 to 40. That's kind of the age group where these patients with low-grade glioma present to our clinic. Usually seizure is their first presenting symptom, but they could also have other neurologic symptoms like stroke-like symptoms and things like that at the time of presentation. So they do present unique challenges, and taking care of patient itself, patient's family, caregivers could be different for patients with low-grade glioma than glioblastoma, where the median age is a little higher, around 65. So there are different nuances in taking care of patients with low-grade gliomas and high-grade glioma. And obviously, survival curves are different, and I have some survival curves here to show you how different low-grade glioma patients tend to do compared to high-grade glioma patients or glioblastoma. And then Dr. Dewey really mentioned very succinctly and really nicely about the new IDH, discovery of IDH mutation, potential for new IDH inhibitors, and we'll talk a little bit about the study that his company conducted, and we'll talk about some of those results and see how that's going to change, or that might change, our landscape in the future. Some of these slides are sciencey, but I'm going to try to, break it down for our audience here today, and we may not have to go through all these things, and I'll just hit the highlights of what each of these slides really want to convey. This is really the pivotal study when we are talking about low-grade glioma. This was RTOG 9802. For those who don't know what RTOG is, there are these groups of institutions that have come together and formulated consortium for for studies where really there's not a lot of industry support. When we do clinical trials, we need a lot of support from a lot of different industry organizations or philanthropy to run these trials. So NIH, which is National Institute of Health, had these 4 major groups where you could get funding from NIH to run some of these studies. So this was a study which really started enrolling patients in 1990s and presented their final report of long-term results in 2016. And this is a pivotal study for patients who have low-grade glioma, who have had surgery, but have some tumor left behind if they are less than 40 years of age, or if they're age 40 or over, even if they have had all the tumor that is seen in the MRI removed, they were included in the study. They got radiation alone or radiation plus this combination of chemotherapy. And this study really, I have graphs after graphs, and you could look at graphs after graphs, but what it really shows is that patients who get radiation plus chemotherapy tend to do better compared to patients who just get radiation. And these curves are really good. If in cancer field, we look at a lot of these curves called Kaplan-Meier curves, and there are several of them. What they really look at is how the patients are doing over time and how many of these patients are reaching certain endpoint over time. And for people who are living in cancer field, we really value these trials and value these curves a lot. Clearly, slide after slide is showing that radiation plus chemotherapy do better than radiation alone. Even in patients with IDH mutation, which Dr. Dewey was talking about, patients who get radiation plus chemotherapy do better than radiation alone, whether that is living longer or whether that is tumor under control for longer. So that's kind of establishing a baseline of what is the treatment for patients with low-grade glioma. But we also know that patients who get a lot of radiation end up with a lot of complications. There are complications of cognitive impairment. There are complications where they cannot go back to work. They cannot go back to driving. Their lifestyle changes. They might sometimes need a lot of help from their family to support them through the rest of their journey. So there's a lot of issues associated with radiation, even with newer techniques of radiation, photon radiation, proton radiation. As patients, you might have heard about all these things, but everything comes with side effects. And as I mentioned, we are talking about a younger population where these patients are contributing to the society or having, are either studying. I have patients with low-grade glioma who are in school. I have patients with low-grade glioma who want to have family. So treating them with very aggressive radiation may or may not be the right way to go. Is a thing that we realized really quickly as we were doing more and more of radiation and chemotherapy for younger patients. So that's where this study comes in, which is the Indigo study, which looked at a specific IDH inhibitor, Vorasidenib, for patients who have not had radiation. So what they did is they included patients with some residual tumors, so they had resection and then had some tumor left behind, or they had resection and the tumor came back 1 year after surgery, but no more than 5 years after surgery. They were randomized to receive this IDH inhibitor, which is kind of a lock and key, right? You have an IDH mutation, then you target it with a drug which really targets that mutation versus placebo. And they were looking at several endpoints. And again, this is technical, what endpoints, but progression-free survival, which is tumor under control for how long is what their primary endpoint was. And then they have really nice curves showing that patients who received the drug had median survival, progression-free survival benefit of more than a couple of years and so on. And across the board, there was benefit of using this drug compared to placebo. The drug was really safe and did not have a lot of side effects. When I was one of the investigators in the study, I have a patient still active on the study. I want to just make sure that I mention that. And the patients have been doing really good with very minimal side effects. So now the company, Servier, is trying to get FDA clearance, and there are dates and things like that set up, and that's publicly available. The question is, how do we incorporate this drug when we were initially thinking about radiation and chemotherapy? So these are some of this is really my last slide, talking about what should we think about when we are looking at low-grade glioma patients, and how do we incorporate IDH inhibitor if it gets approved, and if and when it gets approved. And some of these patients who have been on other IDH inhibitors, how do we handle, and so on and so forth. So here are my questions that I've been thinking when I see my patients. When I see patients with grade 3 tumors who are anaplastic and not technically considered low-grade glioma, I often want to get their tumors sampled again or tested again to see if they are really grade 3. Maybe they are grade 2 bordering to grade 3, and they were labeled as grade 3 by people who are not doing biopsies routinely or testing routinely. So there is a lot of room for testing and WHO grading, and that might change over time. I mean, 2016 to 2021, we had a huge change in classification. We expect that to continue as we learn more about these tumors. Then the big question is, who should get radiation plus chemo first, or who should get IDH inhibitor first? And there's really no guidance on who are those patients who might benefit with one treatment over the other. And we can talk about that for hours. And I was talking to my colleagues at every tumor board. We have patients like these who come in, and we talk about, should we do radiation or chemotherapy? Should we do IDH inhibitor first when it gets available? Then the other question is, how long do we wait after surgery? The study said we should wait for a year for specific reasons, probably related to the trial protocol. Should we really wait for 1 year after surgery? That's something that we have to really think about. For those patients where, who already had radiation and chemotherapy and now have tumor coming back, is there a role for IDH inhibitor there? Or is there a role for IDH inhibitor in combination with chemotherapy and radiation? Something to think about. Then what are the other clinical trials? There are lots of clinical trials which are looking at IDH inhibitors, different kinds of IDH inhibitors, combination with other drugs and IDH inhibitors. So something to keep a track of there is there are lots of clinical trials in this field of IDH mutant low-grade glioma. That's where I'll pause. I can answer these questions on what I feel, but I also want to take time to answer your questions and go from there.
Thank you so much, Vyshak. Someone, there is a question in the chat box. Do you want me to read it to you, or can you see it?
Let's see. I probably cannot see the chat.
Oh, okay. Excuse me. What is the difference between Tipsovo and Vorasidenib? My daughter currently is taking,
I think Dr. Dewey tried to answer that question.
Yeah, we already addressed it.
Dr. Dewey rightly mentioned that, Tipsovo is a IDH1 inhibitor, whereas Vorasidenib is broad IDH1 and 2 inhibitor. Actually, Dr. Mellengoff, who was the principal investigator for the Indigo study, also did a previous study which looked at these two drugs, and these patients had either of these drugs and went to surgery, and they were looking at penetration into the brain, which is one of the huge issues in our field. Yes, chemotherapies work in general, but the problem is chemotherapy works in petri dish. For example, any kind of chemotherapy that we have available, carboplatin, for example, or any of these chemotherapy works really well when these tumors are grown in petri dish. But in humans, where it's in the brain, there are lots of logistical challenges. So this study was trying to look at, let's do biopsies after giving patients one of these IDH inhibitors. And they said that the CNS activity was pretty equal with both these drugs. So there are patients in my practice who are actually right now on Tipsovo, because Vorasidenib is not available, and these patients have IDH mutation. In the future, though, if Vorasidenib becomes available after FDA approval, I am more open to switching these patients over to Vorasidenib, and that's a discussion you should have with your own physicians. And I have that with my patients about that. And when it becomes available, maybe worth considering a switch.
And correct me if I'm wrong, but I believe we're expecting approval by the FDA for Vorasidenib. And correct me if I'm wrong, but that is going to be the very first drug that will be FDA approved for low-grade gliomas, correct?
That's all correct. Again,
Okay.
FDA is reviewing this drug yet, so we have to be very honest about that. And FDA has these dates set up. I think the date that they have to review, and this is publicly available information, is by mid to late August, is when they have to give an answer for this drug, which is the reason why I think Dr. Dewey cannot talk about this drug, and I recognize that. But yes, this will be the first. If that goes through, this will be the first drug that could be approved for low-grade glioma. So we are super excited. And this is going to actually create a lot of buzz in the sense that even at last ASCO, American Society of Clinical Oncology meeting, which is coming up in 2 weeks, there was a plenary session on this drug, and there was standing ovation because this drug has been in the making for so long. I know it only impacts a certain subgroup of patients. It's not for all brain tumor patients, but we're making progress. And if one drug gets across and gets FDA approval, the industry interest in our space of brain tumors is going to explode. And that's important for future drug development.
Absolutely. I actually want to compliment the work, your work, of course, but I also want to compliment the work of the End Brain Cancer Initiative, to be honest, related to this particular drug, because the low-grade glioma community reaches out to us as well for help. And so we're happy to help. The thing that's challenging is we don't really have anything for these particular patients yet, except for, as appropriate, a clinical trial. So the Indigo trial was incredibly, from a patient advocacy organization, was incredibly important to be able to educate patients about and then help them get into this clinical trial. And now we're look at what we're sitting here talking about. We're actually sitting here talking about a drug that targets IDH1 and IDH2, both of those markers. It targets both of them. So we are literally witnessing history and evolution of treatment of gliomas, low-grade gliomas as well. So it's super exciting. So a question came in, and it's the question for a lot of patients who are diagnosed with a low-grade glioma. This is from a caregiver from Wisconsin. If your current treatment plan for a low-grade glioma over the last 8 years has been to wait and watch with regular MRI scans, is there anything else I can do to reduce the chances of recurrence or be better prepared for it?
Yeah.
This is where we're at today, and we might have
Very good question. Very good question. And that actually shows a couple of points, that there are these subgroup of low-grade glioma patients who could just wait for a long time and still not get, have tumor growth several years. The second question of what can I do? You could potentially use things like IDH inhibitor when that gets approved. Although the study said 5 years, these patients who are enrolled in the study were between 1 to 5 years from surgery. These are arbitrary numbers. When I write trials too, we all have to have these numbers. There's no science most of the times on these numbers, and why did we pick 5 years? Why didn't we pick 10 years? And those kind of questions keep coming up after these trials are open and enroll patients. So talk to your physician when this drug gets approved. Is this a good drug for you? What are the pros and cons? And I think this is it seems like at least you're eligible if you have IDH mutation, and that is a way to reduce the chances of tumor growth, and that's exactly what this trial was looking. Now that I can see chat, I see a couple other questions. I don't know, you have a couple of minutes. I can answer these if you
Go ahead, please.
Can the tumor lose IDH mutation, i.e. become GBM? That's a very, very good question. Generally, the answer is no. IDH mutation is a very early mutation that happens in the tumor, and subsequent tumor growth, we have seen that IDH mutation continues. Now, there might be other mutations that add on to that. That can happen. And also, there is a big question of would currently available IDH inhibitor be as effective in high-grade patients? That's a good question to ask, and there's no data yet to suggest one way or the other. And I believe there are going to be studies in high-grade IDH mutant tumors. To be honest, the WHO classification in 2021 clearly mentions that patients with IDH mutation, even if they have grade 4 characteristics, they are not called glioblastoma, they are called astrocytoma grade 4. So we all recognize these patients do better than glioblastoma patients.
So super cool. I wonder if they also meant to ask a question which is a little more generic, which that some low-grade gliomas do progress and become more cancerous. They do turn into GBMs. So when we think about the knowledge, the scientific knowledge that we now know, and we think about the possibility of a drug that the idea is to stop that from happening, it's just an incredible game changer for the patient brain tumor population, as well as healthcare providers. I mean, I think about you and all of our healthcare providers who are serving this patient population, and they will finally have actually something that they can provide.
That's so true. But then, the other point is it makes the discussion very complicated. And it's also the reason why I think most of the patients who are diagnosed, especially with low-grade glioma, should seek out a neuro-oncologist and a team which has expertise in taking care of patients with low-grade glioma. I think it's really important. They should reach out to patient advocacy groups like yours to find the right team that can take care and have this nuanced discussion. Because in the past, it's like, okay, let's go ahead and do radiation for all patients. Now it's really nuanced. And a lot of my patients, even my patients who come to an academic center, I send them to get some second opinion if they really want to. It's really important for them to be comfortable with what we're offering and what we're discussing. And this discussion is getting, more complex, and rightly so. For patients, we have more options.
It's an exciting time. I can say this, and I'm very excited about this. The End Brain Cancer Initiative actually will be working with the FDA a little down the road in order to help with FDA approval related to Vorasidenib. We'll be able to supply patients to speak to the FDA, as well as, of course, we are able to testify to the FDA and uniquely convey the need for this approval for this patient population. And not only for this patient population, but truthfully, it's moving science vastly forward. So it's an exciting time.